Welcome to the Love Lab Podcast, the place to be for honest and real talk about relationships and sex. Whether you're a man or woman, single or a couple, this is the show for you. I am your host, Kevin Anthony, and I am here to help you have the relationship of your dreams and the best sex of your life. All right, welcome back to the Love Lab Podcast. This is episode 371, and it is titled The Science Behind Low Libido. Now, if you've listened to this show for any amount of time, I'm sure you have heard me do shows on low libido before. It is one of the most popular topics. Like, if you're working in the realms of sex and relationship, there's like maybe a dozen topics really that just come up over and over again. And it seems people never get tired of the content on those topics because they're all searching for solutions. This happens to be one of those. However, today we're going to cover it from a different angle. I normally tackle low libido from more of the psychological standpoint because that's more of my expertise. What's going on in the relationship? What are the dynamics between the two of you? What's going on with you personally? All of those types of things that can get in and block your turn on, basically. However, there are also actual medical issues that can cause low libido also. And it's always important to look at the whole. Whenever we're trying to, diagnose something, treat something, we need to look at it in its entirety. So just focusing on the psychological or, what clients of mine often come to me and say was, well, I was experiencing low libido. I went to my doctor and he said, there's nothing wrong with me. Right. So it's like both sides have a tendency to look at these things only from their point of view. So I like to present a more balanced point of view. And that's why I'm actually really excited to have this conversation today, because I have an absolute expert here to talk about the science behind low libido. So I'm really curious to ask some questions and dive in and learn a bit more on the science side of it. But before we do that, a few quick words from my sponsors. Ladies, did you know that the overwhelming majority of men consider receiving oral sex a must in their relationship? Well, of course you did, because men have been asking you for it your whole life. But do you feel confident in your ability to give great oral sex? If you tend to avoid it because you don't feel like you're good at it, or if you feel like you're pretty good at it, but you want to get even better, then my new Blowjob Mastery course is for you. I have teamed up with the amazing coach Reed Wong of Eternal Love to bring you a practical and easy to follow course that is guaranteed to increase your confidence and skill when giving oral sex to your man. In this course, you will get all the secrets to mastering the art of oral sex with step-by-step instructions and multiple live demos. Go to sacredfemininearts.com/BJ Mastery. That is sacredfemininearts.com/BJ Mastery. And of course, Power and Mastery 3.0. It is the latest version of the popular men's sexual mastery course. If you are struggling with erectile dysfunction, premature ejaculation, or simply want to increase your skills in the bedroom, then Power and Mastery is for you. Join the exclusive club of men who have taken their sexual performance into their own hands and become sexual masters. Mastering your sexuality is a key component to becoming the man she has always dreamt of and craves. Don't leave your sexual performance up to chance or the throw of the dice. Become a sexual master today by going to powerandmastery.com/sexual-mastery. That's powerandmastery.com/sexual-mastery. Both of those links are in the description. You can find them there. We got a little something for the women. We got a little something for the men. Okay. My guest today is Dr. Diane Mueller. ND DAOM is a board-certified sexologist with dual doctorates in naturopathic as well as acupuncture and oriental medicine. She is the founder of the sex education center, mylibidodoc.com, and hosts the Libido Lounge podcast, where she helps monogamous couples create more passion, desire, hotter sex, and better communication. Welcome to the show, Dr. Diane.
Thank you, Kevin. And I just want to intro this with piggybacking off of what you just said in your intro, because one of the things I have really found when people are kind of open to this idea of oh, I should look in all these other places for a root cause, is another layer of it I find is that it's so common when people are looking for root cause. And I'm saying this as cause singular for a particular reason because it's so common that people are like, oh, this is the root. And we think oftentimes in holistic care when we're searching for the reason for something like low libido, like there's this one magical root cause. Maybe it's that mental emotional, like you're talking about. Maybe it's the physical. But I want to, just kind of piggyback off what you've said and really help the listener to understand. Like, I would look at all of the content that we're talking about today almost like a pie chart. And in order to have a amazing sex life, an amazing relationship, a healthy libido, you're going to have a wide variety of numbers of pieces of pie that need to be addressed. So it's very, very, very common, for example, that people will get on testosterone replacement therapy and then all of a sudden they'll have an improvement in their libido. But if their relationship isn't well, if like there's problems in their communication, then after 3 weeks of seeing that libido jump up, then the libido falls back down. And in that situation, it doesn't mean that testosterone's not important. It just means that if we're looking at this as a pie chart, testosterone's one piece of the pie, and we need to make sure that we're addressing all of them. So it really helped the listener kind of orient to today's content with listening to this as a, hey, we're looking for the root causes, plural, because in 15 years of doing patient related work, I've never seen one single case after working with thousands where there's only one root cause. So, just to kind of orient, people to that as a framework for today's call, I think is important.
Yeah, that is a very important point to make, is that it's often not just one thing. And then the other thing is that, one factor can potentially exacerbate another factor, right? So a particular factor may not be that big a deal in and of itself until it's combined with other factors.
Correct. Yep. And then we get into like the vicious cycle of, cause and effect, right? Where we have like an emotional, say, imbalance in the relationship. Well, that can create stress. And then we have stress hormones elevate. Well, when the stress hormones elevate, we tend not to handle our emotions as well. We tend to be more reactive, and that can lead to even more emotional, imbalances. And that cycle continues. And that's just like one of many kind of like chicken and the egg things that can happen with this. So it's more around like, okay, well, less about finding, okay, well, what is the chicken, what is the egg, and more around saying, okay, well, all of these areas need to be addressed. And absolutely, like you said, I see it too. It's just that compounding factor of how all of these things work together that oftentimes creates that bigger problem.
Yeah, so let's just dive right in with some of the medical issues that can potentially be in the way. I have a list of 8 of them here, and we'll see if we get through all of them or not. Maybe we will, but let's just start with the top of the list. The first one I have on the list is circulation, and in parentheses, erection issues. So let's talk about that, because honestly, there's no way we can talk about the medical issues with libido here without talking about guys' dicks, at least for a few moments.
Well, guys, dicks, yes, but also females' vulvas, right? Because I think this is one of the big kind of aha moments I want people to have here is that anything we're saying about these physical root causes, whether it's we're going to talk about this or pelvic floor dysfunction, we're going to see that in the conventional medical world, there's kind of a tendency to be like, oh, circulation, issues as far as we need that erectile blood flow to help that penis be hard. Like that comes up a lot. Or like pelvic floor pain, people are like, do your Kegels. That comes up a lot for women. But what we actually see is these kind of things are important for both men and women. So yeah, circulation is obviously very, very much needed for that healthy blood flow to the penile tissue, but also to that vulva. It is helping that vulva become nice and engorged. It's helping the vagina become lubricated. That is not just an estrogen, testosterone thing, that's also a circulation thing. So there's a huge relationship then with feeling, sex feeling good for a female, as well as sex being possible for a male when it comes to circulation. One of the big problems I see here is that most of the time when people go and say, hey, I'm having erectile dysfunction, I'm having vaginal dryness, many times like the proper testing is not even done to look at this. So for example, it's not uncommon that a doctor would say like, well, let me look at your blood pressure, let me do a basic lab to see if your kidney function is okay. And let me run your cholesterol numbers. And we run those basic things. And it's like, oh, your cholesterol looks decent. Your blood pressure is fine. You don't have a kidney problem. So there's no blood flow problem. You still might get a little blue pill just to kind of help out. But the problem is, when I talk to cardiologists that I work a lot with sexual dysfunction, one of the things they tell me is, especially for men, that erectile dysfunction is one of the first signs that actually drives them to a cardiologist appointment. Now, if we make it all the way to the cardiologist, we're probably going to get more testing done than just blood pressure, kidneys, cholesterol, right? But a lot of times people, when they do those basic tests, are like, they're told they're fine. They don't think there's any other problems. And the problem is we see, for example, like cholesterol numbers don't correlate very well to plaque on the arteries. So if I'm going to say, okay, one of the biggest problems with blood flow is when the arteries harden and they don't pump blood well, when they stiffen because of that plaque on the that plaque, that's what's really leading to a lot of the vascular problems. Well, if I do an ultrasound or a CT scan where I'm actually looking for plaque on the artery, and I correlate that with cholesterol in the blood, cholesterol in the blood actually does not indicate very accurately what's actually happening at that arterial level. So if we don't actually do and work with our cardiologist or have our primary care order a ultrasound of the carotids of the arteries called a CIMT, or do things like calcium scores, then we are missing this opportunity to say, oh, what's actually happening on the vascular level? And we could have a problem there that we're missing because we just did those basic labs.
Yeah, I was reading the article the other day that was talking about basically what you were saying, not in relation to, erectile dysfunction or anything like that, but it's just talking about cholesterol numbers and relationship to, formation of plaque. And
Yeah.
I'm reading this article and it's like this new thing that they just discovered. And I'm laughing because I'm like, I have known this for 20 years now. And it is just yes, it's a mainstream article, but it's literally just on the fringes of the mainstream right now. In other words, what you said is there's no correlation between how high your cholesterol number is and the buildup of plaque. Why is that? Because it doesn't matter how much cholesterol is in there. What matters is how damaged the insides of your arteries are. So what you got to look for is what's damaging, what's causing inflammation, what's scarring the insides of I'm on a soapbox now because I get so irritated by this stuff. I'm like, I am not even in the health industry. I have known this for 20 years. And
Yes.
still in the general public, it's not well known, or even in most regular doctors don't quite get that. Um, and I'll say this also. I've worked with a lot of men with erectile dysfunction over the years, and whenever they come to me, the very first thing I tell them is, have you been to your doctor? Has he checked your heart? And almost every time it's like, no, why? And I go, because erectile dysfunction is one of the primary indicators that you have a problem with your circulatory system. I'm like, the first thing you need to do is go get checked by your doc and then come back and we'll work on the rest of it after that. But we need to at least make sure that's working. So
Exactly right.
I'm glad that you talked about all of those things because that's one of the points I really wanted to make here as far as on the men's side, right?
Hmm.
So when men are like, oh, I'm having erectile dysfunction and I'm having difficulty getting up, I want them to understand there could be a legit medical issue there that needs to be addressed. And I also want them to understand how that can also affect the psychological end of it, right? So this is what we talked about earlier, right? There's a physical, and now it's having an effect on the psychological because it's like, oh, now I can't get an erection, and so now I'm starting to have performance anxiety, and that anxiety is raising my stress level. Maybe that's now affecting my testosterone level, like all this stuff. My confidence is going down, right? So it's all kind of tied together. And I wanted people to understand that from the men's side. But now I want to get in and I want to hear a little bit more from you on the female side of it. Let's talk a little bit more because you started to go there and you talked a little bit about some of the issues that circulation can cause in women. Let's talk a little bit more about that.
Yeah, I mean, in a lot of ways, it's very, very similar, right? We are certainly, as women, we are certainly not like women without penises or, humans without penises. Our parts do, in many ways, work differently, but in many ways, there's a lot of similarities. And the similarities are that we do need blood flow to the tissues to engorge, to feel good, to, soften the tissues so that penetration feels good, to actually bring more blood so that things like cunnilingus, like oral sex feels good. And so, with that, the biggest difference between the way testosterone impacts blood flow versus estrogen impacts blood flow really is the quickness of it. So, we need that same level of engorgement as women. So, that same issues apply. You need the same lab tests from a standpoint of looking at cardiovascular health, and that should all be considered. Now, just on a day to day, how does this actually show up in the bedroom? One of the biggest differences is really in the cycle of arousal is that because what testosterone does is testosterone allows that quick blood flow to that penile tissue so that engorgement happens relatively fast. What estrogen allows, it's a much slower impact to the circulation system. Now we know that estrogen is incredibly important for cardiovascular health, right? We know that for sure, that when women go through perimenopause and menopause, the earlier they start on things like estrogen replacement therapy, the better cardiovascular system and the better heart health has been shown in studies. But from like a day to day, how does this transfer into low libido? It's actually quite similar to men. It's just that for women, the result of improving circulation is still going to mean, hey, if everything's working well, it's still going to take longer for that blood to actually flow to the genitals and get engorged, just because that's the nature of how that works for an estrogen dominant human.
So that's a really interesting point that you just brought up because men who are aware understand that women take more time to get aroused. But there's still a lot of men out there who approach sex with a woman as in, I don't understand. Like, I'm ready to go. Why are you not ready to go? Right. So I think it's really interesting to hear that even for the ones that may be aware, they are probably not aware that there's a physiological reason behind it. And I think a lot of times they just think it's a psychological reason. Oh, well, it just, they got to get more out of their heads or whatever, it is, it's going on. But that's really interesting. And I have to say, like, I don't want this to sound the way it's going to sound, but there's no other way to say it, which is, I've done a lot of interviews. I've interviewed a lot of experts, and
Yeah.
it's not that often that I learn something truly new that I didn't already know. I just learned something truly new. I
Oh,
didn't
great.
know that there was a difference in how quickly estrogen versus testosterone increases circulation.
Yeah.
That's totally new.
Yeah. Yeah, and it's interesting too, and like what you're bringing up. Like I do think mm, there's this like almost like Freudian belief that's still circulating in our society of the penis and penetration is like the predominant like say what's the best way of saying this? The predominant superior, that's the word I'm looking for, the superior way of pleasing a woman. And with that, I think one of the problems that we've seen with arousal and desire, and to your point of, hey, many men are still, even if they're aware, still thinking this is psychological, that women take longer. But some of that is just based upon the fact that even in school, even like both of my doctorate programs, when we talked about arousal cycles, so even at a medical level, we were talking about this four-phase model that applies to men. You get this kind of excitement, you get this kind of crescendo, there's this plateau before the crescendo, and then you kind of go into this refractory period. And so we were taught that men and women work the same way. But it's really interesting in psychology, and I'm sure you know this, so stop me if you've gone here, you don't want me to say this anymore. But for men, desire comes before arousal. And for women, arousal comes before desire. And so the way that looks for men is like, oh, I see this beautiful human walking across my kitchen. Look at her breast. look at her ass. Now I'm like, okay, now I'm thinking all these thoughts. That's desire, that's the mind, and the arousal follows. And so, another interesting thing with the difference of these hemodynamics, with the difference of the circulation for men versus women, is for women, it's arousal coming before desire. So, again, desires of the mind, that's like, I want to have sex, I'm horny, of the mind. Arousal's the body responding. So, for women, so many women are just waiting, and so many men are just waiting for their female partner to be like, wow, I'm really ready for sex. But what's happening for her is that she needs to be aroused before she even has those thoughts. So, in order for this blood to flow, in order for that to happen, because of that arousal cycle, that's where we get into the conversations around like 20 minutes of warm up, 20 minutes of foreplay, 20 minutes of sensual massage. All of that, what we're doing is we're touching her body, and what we're doing in that is we're allowing her to actually feel the sensations in her body, to drop into those moments. Because that takes longer too, because she doesn't have the focused, compartmentalized awareness of the man. She has this diffuse awareness where she's taking things in all the time. So it actually takes her longer typically to drop in and be truly present with that body, her body. And as she's doing that, as she's more present, that's part of what's then driving that circulation as she's like, oh, I feel these sensations, right? That's what's driving that circulation to her genitals. And this is where a woman like will oftentimes just decide to have sex, even though she's not in the mood and she's gonna do it anyways, because it's her obligation, right? And then 20 minutes into it, she might have a thought, and that thought is, hmm, this is actually feeling good. Like, why don't I do this more often? And that's because that's the desire. It took her 20 minutes of being aroused to actually have that thought of, like, oh, I like this. Like, I want this. I'm kind of turned on. So the desire comes second after she's aroused, not the other way around.
Yeah, and that's a big difference, and definitely one that I don't think a lot of men understand.
Yeah.
Um, is it is that true 100% of the time for women, or is it true predominantly, and there are times where, she has desire first?
Oh, it's definitely not 100% of the time. I don't think there's anything that's 100% of the time. And in particular, what I see is like, in particular, that new relationship energy, desire can come first and often does. Also, another time that desire tends to be earlier on for a woman is when she's on vacation, when she's less stressed, because it really is super related to how much information she's taking in her brain. Like, for example, this is like the classic example I give for people is, wow, man is, this is so stereotypical, but I use it because people get it. Man's watching a TV show, football or whatever. Woman's trying to get his attention, and she's like, honey, 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 and he's just so focused he doesn't hear her. Like, that's the ability of the masculine brain to like focus, versus like a woman walks into a room and immediately, immediately when I'm like, I'm in my boyfriend's house, I can see the fact that, wow, there's a spaghetti stain on the floor that he forgot to clean up from last night. There's a picture over there that's out of place. The kids are doing all these different things. Oh, this, and I'm taking in 20 different things when I walk into the room that he probably is not, aware of at any moment. So for the woman, that's how the female brain works. Both have their superpowers, right? And so I think that's like where, what's related to like how easy it is to have that desire around, like, if the more she's able to be in the present where there's not all those stress and there's not 20 different things consuming her attention, the more she can actually tune into the moment. So that's what it seems, and the couples that I've worked with, that's what it seems to be most related to, is like how, what her state is at any moment and how quickly she is able to drop those things. And in the new relationship energy, even if she's busy, because of all those other chemicals in the new relationship energy, because the newness, that newness, or even from a safety and survival, standpoint, requires that extra focus. And so it's, again, it's like, okay, well, how much is she able to drop and like focus super easily on that moment? That will be directly related to how quickly she can get into that desire a lot of the times.
Yeah. And I asked you that question because I did want the men to hear that, because I a lot of times I do these shows and like information is coming out and I can already hear the YouTube comments and the peanut gallery and I just want to preempt like a lot of that stuff. So when we were talking about the fact that, it's generally arousal first, then desire, I could already hear the peanut gallery. Well, my woman, blah, 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 blah. Right. And so
Yeah.
I kind of wanted to show that it can happen the other way as well. But like a lot of things, women are predominantly one way, but it doesn't mean exclusively. And same with men, right? So, perfect example on the opposite side is we were just talking about, how men have this ability to really focus and not necessarily take in the 40,000 details. And that is very true. That is absolutely true of the masculine. But we can learn to take in all of those things. If you take, say, somebody like maybe an investigator, right? The second he walks through that room, he's trained to notice every single one of those little things. I worked when I was very young in my 20s. I worked as a lifeguard for a number of years. And that was a real struggle for me because I had to be taking in everything that was going on. And there's how many, dozens of people, 100 people, and I'm trying to keep track of where they all are and that sort of thing. And I really struggled with that. I had to develop it over time. Like, how do I take in the whole picture and not miss anything rather than being singularly focused on something? So I just kind of wanted to make that point that we both can do both, but we do have a predominant way that we tend to operate. And for women, you're right. That used to show up with my wife in ways outside of sex too. Like it wasn't exclusive to sex. Like she used to say all the time, we'd go out for sushi and I'd want to order like some yellowtail. And she'd be, yeah, and then we'd order it and she'd eat it and she'd go, oh yeah. Now that I'm eating it, I forgot how much I love yellowtail. And she would do the same thing every time for years. It was hilarious. We used to laugh about it all the time.
Yeah, it's true. And it's like, and like you said, for women too, I think the other point I want to bring up with the female there is like it is a practice. And like the way I say for all humans, but do think this applies a lot to women, is the practice of experiencing pleasure is directly related to the practice of being present. So the more present we are with like our mind with our lover, feeling the sensations, looking into their eyes, just being fully immersed in the experience, like the more easily we can be in the presence of that, the better. And we know from like meditation, from visualization, from mindfulness-based stress reduction techniques, all of these things that are like teaching about being in the present, all of them are practices. And so the more we practice is the better we get at it. And the same thing is for like, okay, practicing dropping into the present. Like the more we practice that throughout our day, not even just from a standpoint of sex, but I also think from a standpoint of whatever we're doing, just how much can we drop into the focus of the moment versus the multitasking, that we often do as humans. All of that is really practice for the bedroom. And I think the other comments that I think is probably pretty important to make, and maybe I'm going to lead you to some YouTube comments on this, but but is for the people that are like, oh, my wife that doesn't do that, she's like just wants me all the time or any of those things. My suspicion is like the more we can drop our ego, which is not always easy to do, and realize that everybody has moments, and even if there is desire that is there most of the time, my guess is there's probably times where there's moments that it's being forced more than it needs to, and maybe the desire isn't as much as it's being led on to. And it doesn't mean that anybody is like a bad lover or all of these like crap things that are going around with like me. It doesn't mean any of this. But I'd really encourage people, if they're like kind of shutting down, to be like, well, that's not my wife, that's not my partner, to actually be curious to say like, huh, is it possible that that could happen sometimes? And is it possible that I could be curious enough to ask my partner this and to see if that's happening, even if it's 5% of the time, to see like, are there opportunities for us to actually grow deeper in those moments because I'm actually taking the risk to be curious about it? Because I do think no matter where we're at, there's almost always the opportunity to go deeper. And if we're saying and we're coming and hearing information with like, oh, not me, not me, not me, usually what's happening there is we're shutting down our curiosity to learn more and to go deeper. So I just wanted to throw that out there and hope that you don't get too many bad YouTube comments about
Oh, that's okay. Any engagement is good.
that.
But that, I mean, that's great advice. And I would say that, anybody that shows up and says, that's not at all, my situation, I would be willing to pretty confidently say it's probably because they're not paying attention as deeply as they could be. Because we're not robots, we're humans, right? And we
Yes.
fluctuate and we vary. So uh, great advice. Okay, we're about halfway through the show already, and we've only covered one of the eight. But we did talk about something else that I really wanted to talk about, which was the differences in arousal and desire. So that fit in right where we talked about it perfectly. So let's do this. Let's pause for a short break. When we come back, I want to pick a couple more of the things. There's a few here. I'm just going to cherry pick out of the list because there's a few that I really want to talk about that I think people may not be as aware of. So we want to bring that to the front. So we'll do that as soon as we get back. All right. Ladies, are you tired of always picking the wrong guy? Does it seem like there just aren't any good men out there? Are you struggling with your sexuality? Or do successful relationships seem like a mystery you can't quite crack the code on? And then it's time to get help. Check out my women's relationship and sex coaching program at kevinanthonycoaching.com/women. In this program, we will work on removing sexual shame, becoming confident in your body, learning the sexual secrets that drive him wild, what to really look for in a man when dating, how to break old patterns like always choosing the wrong guy, and so much more. This is your opportunity to learn everything you have ever wanted to know about men while also creating real lasting change in your life. So go to kevinanthonycoaching.com/women and sign up for a strategy call today. Okay. So we've covered number one out of the eight, which was circulation. It was a great conversation and really took us into some other interesting stuff that I think that was important. I want to just cherry pick a few more things here that I don't think people necessarily maybe are as aware of. So, for instance, number four on the list is inflammation here. I mean, how is there a link between inflammation and low libido?
So many ways. So, inflammation, I always like people to remember, is never the root cause, right? So, we have to say what is causing the inflammation. So, infections, toxins, diet, all of these various things can actually cause inflammation. We see that certain types of inflammation can actually inflame the brain. When the brain is inflamed, one of the things we see is that the upper regulatory parts of our hormonal system, which are known as the hypothalamus and pituitary, when we have certain things that are inflaming us, and when these inflammatory molecules enter the brain, one of the things that can happen is those centers can stop signaling correctly places like our thyroid or our testes and ovaries. So we can see actually a direct link sometimes from inflammation to turning down our hormonal cycle or to turn down our thyroid. And of course, like when our thyroid's low, we're exhausted, right? Nobody, when they have like low thyroid, I actually was just going through this recently. I had got my thyroid checked and it was so low. And I was at a point where I was like, I knew it was almost certainly my thyroid because I was at a point where I was like, I would try to leave my house and I would like, I'd go for a half-mile walk and I would feel like I was like dying from low energy, right? Like, not a lot of motivation to have sex when you can't even walk for 10 minutes without feeling like you're dying. So, point being, so like those types of ways, we can also see also related to our circulatory conversation that usually the main root cause of the circulation actually becoming a problem and the plaque being on the arteries. We don't just build plaque on the arteries for no reason. One reason we build plaque on the arteries is there's so much inflammation, and these inflammatory molecules will actually nick the blood vessels. And when the blood vessels are nicked, well, we don't like to have this as a damage. So the plaque on the artery wall is actually a compensatory mechanism to say, hey, we have these inflammatory molecules causing this damage. We don't want a hole in our arteries. We don't want this nick. So we're going to put a patch on it, is what the plaque is. So it's, kind of back to say, it's like also related to that circulation conversation where, again, what is like the precursor to the inflammation and what is the result? So the precursors can cause the inflammation, but the inflammation can affect kind of some of those other root causes. So it really is a like back to that chicken and the egg thing we were saying is like, yeah, inflammation can do this, but it's going to be through things like impacting our hormones, impacting our circulation. We see that when we're neuroinflamed, when we have things like toxins, there's so much research on mold toxins, on toxic metals, on pesticides, glyphosates of actually being neurotoxic. So when we're neurotoxic, what that means is that our nerves are not working correctly. And so in order for us to have proper arousal, we also have to have our nerves from our brain and from our spinal cord sending the right signals to the genitals. Right? It's not just about circulation, it's about that nervous system control there. We have to have muscles relaxing when they're supposed to, muscles contracting when they're supposed to, our arteries doing the same. And all of that is under control of our nervous system. And when our nervous system gets inflamed, those proper signals don't happen. And therefore, we can have the resultant lack of responsiveness of our erogenous tissue because of that. But again, it's like back to that kind of vicious cycle, really, is related to that inflammation.
Yeah, well, it's a good example of what we talked about earlier, how there can be multiple things happening simultaneously and affecting each other. And, one of the reasons I picked inflammation from the list is because it's starting to gain some more traction, in the mainstream these days. But there are a ton of people out there that are operating day to day with massive inflammation in their bodies, and they are completely unaware of it. And mainstream medical science, a lot of it doesn't understand this. So they like you said, they can't walk down the street without being exhausted, right? And so therefore they have no drive for sex. And then they go to their doctor, and their doctor's like, I can't find anything wrong with you. Like, I don't know. Go see your psychiatrist, right? And it's because they just don't really have an understanding of that inflammation mechanism. And we're just starting to understand a lot of the things that are causing it. You mentioned a pretty good list of them. There are others too. One of the big popular ones out in the media right now is the seed oils and how they're potentially causing inflammation. So, it's another great example of how all of this stuff kind of ties together, because you also then brought in the idea of thyroid issues, which is another one on the list. So, since you brought it up, let's just go there. Um, Obviously, you already talked a little bit about how thyroid impacts it. I'm not in the health, profession at all, but it is something that has been, an interest of mine for decades now, and I do a lot of reading on this, and so like I have a lot of things that really irritate me about the mainstream, and so like a bunch of them are coming up right now. I'm realizing as we're talking about this, like thyroid issues is another one of them, because it's another area where we see a lot of mainstream doctors do not understand how the thyroid actually works. And a lot of times they will prescribe synthetic thyroid hormones that actually do more damage than good. Now, that's that's about the extent of my knowledge on it. I want you to jump in and talk about that a little bit.
One of the biggest problems with thyroid is the way we're testing for it. So if you're listening to this and you're like, well, it's like I'm going to tune out because I already got my thyroid tested and I know I'm fine, I would actually encourage you to tune in extra hard right now, because I see this over and over and over again, this problem that I'm about to describe, which is the most common test that conventional medicine is running for the thyroid is TSH. And there's a few problems here with this, but one of the first ones is that TSH is not even thyroid hormone. TSH is a brain hormone. It's made by our pituitary gland. And what this gland does is it secretes this TSH, and its job is to tell thyroid to secrete thyroid hormone. So we can have situations when we are testing this and we're like, oh, well, the TSH looks good. The brain's doing its job, but the thyroid is not responding. So, very commonly, we are not even testing true thyroid hormone when we're doing this test. And we're just testing this brain and saying, well, if the brain's working fine, we're just assuming that means the thyroid's working fine, which is just ludicrous when we understand how this all works together. The secondary problem with that is that thyroid hormone has two forms of it, two main forms. There's other forms too, but two main forms. The one is called T4, The other call is called T3. And T4 is inactive thyroid hormone. What that means is that it doesn't do anything. It doesn't give you energy. It doesn't help with hair. It doesn't help with mood. It doesn't help with bowel function. It's inactive. And that it remains inactive until it actually turns into the active version called T3. Now, T3 does all what I mentioned. So it helps with energy, it helps with mood, it helps with hair, it helps with bowel function. So sometimes I see conventional docs giving like another test to somebody, which is usually T4, which is still not even testing active thyroid hormone because again, we can have the brain making all the TSH just fine. We could have the thyroid making the inactive form just fine, but it could be a conversion problem where the thyroid is not converting it into the active form T3. That conversion takes place mostly in the liver and mostly in the small intestine. So, if we have a problem, let's say our liver's inflamed from toxins, that could actually be a reason why we have that low conversion of the inactive T4 to the active T3, because much of that conversion is going to happen in the liver. And if toxins, the body's too toxic and the liver's inflamed from it, probably not going to be working as well for that conversion. Then we have other problems where it's like, even in monitoring those are just talking about the total output. Then we have to talk about the cellular utility because we can make as much as we want, but if our cells are not able to use it, then it still is just going to run around in the blood and look fine, but it's not going to actually impact the cells, which are the most important thing. So, from that standpoint, we need to measure what's called the free version of the hormone. And so, the free version are like the active versions the cells can actually use. And then another component, and this is like not even getting into the autoimmune side. So, try not to get too deep in the woods, but to really illustrate the problem here. Another thing that's not commonly tested is called reverse T3. So reverse T3 is another molecule from the thyroid that will block regular thyroid from working. So if I have all of my active cellular available thyroid hormone, which is called free T3, and that's a really good marker to look at because now I know I'm converting it, my cells have enough to use, all of that looks really good. But if I have too much of this other reverse T3, it'll kick the regular T3 off the cells. And so the cells can't even use it, even though it's available for them. So one of the problems is that we're not getting this full, complete picture. And we could throw on, like I said, thyroid antibodies as well and go down a rabbit hole there. But then the other big thing, and then I'll pause here, but the other big thing for people to understand is the reference ranges, the what we're looking at from a lab perspective to say this is normal, this is not normal, are not based upon a healthy population. The way we get most of these reference ranges is we collect all the data, the labs of everybody that has their thyroid looked at, and we say, oh, the top 2.5% are problematic. The bottom 2.5% are problematic, and the 95% in the middle are normal. Well, this would be really great and probably a really useful thing if we were taking that calculation and looking at healthy populations. But we're basically saying, okay, anybody that's testing their thyroid hormone is probably most of the time going to have a lot of thyroid symptoms. And so we're saying, okay, if everybody that has thyroid symptoms, you're only considered bad if you're like extreme on either end and everybody else is normal. So, and then in functional medicine, what we're really doing is we're saying, okay, well, where are people actually testing their thyroid when it is normal, when they feel good, when they're like, well, what does it look like when somebody's like, I have energy, everything's going well. And so that's what we're really doing in like optimized medicine, like functional medicine, is we're looking at that much more narrow range to say, oh, even though you might not be diagnosed by your doctor as having a severe problem, if you're not in that optimal range with these things, you could still have what we call a subclinical thyroid problem, which is really still a thyroid problem. Your thyroid's still not working optimally, you're still having symptoms, but we're just going to take an intervention now when it's like, a minor thyroid problem before doing the watch and wait thing to see how bad you have to be before we actually, step in and do something. So big point saying like a lot of like thyroid is so directly related to vitality, to libido, to drive, to desire. And a lot of times, due to the tests we're using, as well as the way we're interpreting the test, it's being missed.
Yeah, you brought up some really important points there, and that's why I'm glad that, we've picked some of the ones that we have because again, as I mentioned earlier, people will go to their doctor and their doctor will say, there's nothing wrong with you. We did the tests, all is good. Like, go home and figure it out kind of a thing. And then people are left with really no solutions because they know something's wrong, but their doctor tells them there's nothing wrong, right? And they just get stuck there. And a lot of times they'll lose hope. And so it's really great to talk about these things because then people can ask better questions when they go to their doctor. So for instance, you really just clearly explained that they're not even testing for the right things. So now, when somebody goes to their doctor and they think they might have a thyroid issue that's affecting their libido, they can ask specifically, what are you testing for? And if you get an answer other than, I'm looking for, free T3 in the system, like, then you either need to ask for them to do that. And if they're not willing to do it, go find yourself another doctor, right? Another interesting thing that you mentioned was this idea of the reference ranges. If people aren't aware that these things change all the time, this is another important thing to learn. Like, for instance, I mean, I'm in my 50s now at this point, and one day I was looking at a chart for like average weight for somebody my age and my height, and I'm looking at this chart and I'm going, this isn't right. So then I did a search for the same exact thing, but I wanted the one from the 70s, right? Oh, are those charts radically different, right? So the thing is, you're exactly right. Like you're told that this is a normal range, but it's only a normal range in a sick, diseased population. Like testosterone is another great example of that, right?
Mm.
Because testosterone levels have plummeted by about 50% in just 2 generations, right? So now we say, oh, your testosterone level is fine. Well, is it fine though? Because we're basing that on a normal range that's probably 50% less than what a normal range was 50 years ago, right? Or maybe a little bit more. So that's part of it, right? And then we're basically saying that uh, you're in the reference range. But then the other thing that you mentioned is how many times do people get tested when they're feeling good? This is a big problem I have with guys coming to me with testosterone issues all the time. They're 40 or 50 years old and they go, I went and had my testosterone tested and I'm low. Okay, what's your number? Well, the number's in what they call the reference range. But the thing is you don't know what your number was when you were younger and when you were feeling good. And it varies a lot from one person to the next. For one person, 1,000 might have been normal for them. And for another person, 700 might have been normal for them. Now you go out and you get a test, and the test comes in and says, you're at 600, right? Oh my God, my number's so low, right? It's like, maybe, maybe not, right? So these are all important things that people need to know when they're going and having these tests done. They need to ask these kinds of questions, like, and obviously, if you can, and of course insurance never pays for it, but if you can, have those things done, those tests done early so that you can establish some reference ranges.
Yeah, exactly. I don't know what our obsession is in medicine with like saying that majority of people are normal versus saying like, wow, look at these changes we've had. This is interesting how we are getting sicker and sicker in these ways as a population. But we have this obsession with being like, most people are normal, most people are good, which is, it's really, really problematic because most people are told they're fine, but yet they're still running around with symptoms. So, I think the point is, in my mind, is like the self-advocation is just so essential, and people actually seeing that if you're fatigued, if your sex drive is low, if you feel like there's something going on, advocate for yourself and find a doctor that's actually going to do their job and find it for you versus saying, "Oh, labs look good, you're good." If you don't feel good, if you feel like something's off, I guarantee something's off.
Yeah, and that's an important point. It's like, trust yourself. If you feel like something is off, trust that, go with it, go see your doctor. If you're not getting the answers that you would like, find another doctor. Get at least two opinions. Sometimes, honestly, I have literally seen situations where it has taken somebody 3 or 4 doctors to find somebody that actually went, oh, no, here's exactly what's going on, right? Because all the others didn't do the same testing or, whatever it is. It's unfortunate, but that's the world we live in. You got to really do your research and try to find the best and look for more than one if you're not finding answers to your problems.
Exactly. So well said.
Well, I know that you have a very tight schedule and that you need to get going. And we are almost at the end of the show anyway. So I don't think we have time to dive into any of the others. But just to quickly mention some of the others on the list. So, number one was circulation. We talked pretty extensively about that. Two is hormones. We started to talk about that, but there's definitely more that we could go into as far as menopause, andropause, that sort of thing. We didn't cover neurological system, but we did cover inflammation, thyroid issues. We briefly mentioned stress, but there's definitely more we could talk about there. We didn't get a chance to get into pelvic floor dysfunction or the dopamine system, but I just wanted to sort of mention those for people who are listening. We're talking about the science behind it. What are the physiological things that could potentially be affecting your low libido? And that's the full list. We talked about as many of them as we could squeeze into in this show today. But if you want to know more, you can always reach out to Dr. Diane. So now is the perfect time to tell people how they can find out more about you and your work, anything you want to promote.
Well, I got a perfect free way for you guys to get started, which is going to take my libido quiz at libidoquiz.com. And what this is a free quiz that you put in your symptoms. It's very, very detailed. And when you put in your symptoms, it's going to spit out your top likely root cause or two. And it's not only going to tell you that, it's going to follow up with an email with a list of lab tests. So if you're like trying to like take notes on today and what's important, what did we not get to, a really great resource is go take my free quiz because it will give you follow-up information and a lot more detail on what we talked about today. So again, super easy, libidoquiz.com. And also, I go through these and more in my newly released best-selling book, which is called Want to Want It. So you can find that super easy as well. You can find that at wanttowantIt.com. So those are generally the two easiest ways that will really add on a lot on top of what we covered today.
Awesome. And those links will be in the description. So please go check those out. Well, Diane, thank you for coming on the show and sharing your expertise. I really did appreciate it because I really appreciate the fact that you're coming from that more holistic point of view and that we can really go deeper than what maybe your typical doc would do. So people are not only getting the benefit of, having a doc come on and talk about these things, but also somebody that I think has a deeper level of knowledge than most. So I really appreciated that.
Thank you, Kevin. Thanks for having me.
All right, everybody, that's all for today's show, and I will see you next week. I hope you liked this episode of the Love Lab podcast. If you enjoy this show, subscribe, leave me a review, and share it with your friends. And for more free exclusive content, join me in the Passion Vault at kevinanthonycoaching.com/vault. That's kevinanthonycoaching.com/vault. Thanks for listening. And remember, as Celine used to say, you're amazing.